Okay, so I'm sorry, that was a mute. Do you hear me now?
Yes, we can hear
Yes,
you.
we can hear you.
Okay, I'm sorry. That was a mute. So the first case is about a patient with myocardial infarction, and this is the first image. And I want to explain to you the things that you need for the pathology small group lab exam from this image. What you need here is to compare between a troponin and the CKMB, or the total CK. Of these markers, the most sensitive and the most specific is troponin cardiac marker. That is the most sensitive and the most specific. Now, the second thing that you need to know about their plasma half-life. The plasma half-life of CKMB is 72 hours, meaning after 72 hours, it will come down to the baseline level, whereas the plasma half-life of troponin is 7 to 10 days. What is the significance of this? The significance of this in patients who may have reinfarction on the fourth day after the CKMB that has come down to baseline level, that it may rise again when there is a reinfarction. So at the same time, the troponin may be still high on the fourth day. If there is an reinfarction, it will jump up again. So that's about the plasma half-life. So please be aware also of the plasma half-life of these cardiac markers, because they mean they are of some significance. The third thing that you need to know is the CK index. The cutoff point for the CK index is 3 to 4. Anything above 4 is consistent with myocardial infarction. Anything below 3 is consistent with rhabdomyolysis. These are the 3 points that I want you to remember about this. Now, if you look at the normal values in the lowest row, tells you that troponin is 0 to 0.03, normal. CKMB 0 to 5. CK index 0 to 3. So here you find at the time of admission that troponin is normal, CKMB is normal, and the CK index and the total CK slightly rising. And if you look at the 24 hours, that this is basically the peak for troponin, the peak for CK index, the peak for CKMB, and the same for total CK. And as you notice that at 72 hours, look at the CKMB that came back to normal, but for troponin, it was still high. So these are the points that I want you to understand about this image. Any question before I move from this image?
Sorry, I do have a question, Dr. Ramadan.
Yes,
I just wanted to clarify, did you say anything below 3 for the CK index is rhabdomyolysis?
absolutely. Because CK index is basically an equation in which the CKMB is divided by the total CK and multiplied by 1,000.
Okay, so that's still determined like normal though, right? Because it's not
Yes.
MI.
Yes,
Okay, thank you.
sure. So in this image, the objective, the teaching or learning objective of this is to show you that emphasize in you that the plasma half-life of CKMB is 72 hours. So by the end of the 72 hours, it will come to a baseline. So if there's a reinfarction here, that say on the fourth day, then it will rise up again. And as you see that at the end of 72 hours, troponin is still high. So if there is a reinfarction, it will again jump. Now the question is, which is more sensitive and specific for reinfarction? Still, it is troponin. So here, the idea of this image is to show you that in patients with atherosclerosis, that if the atherosclerotic plaque is including 70% and above, it's only at this point that patients start feeling the anginal pain. So before less than 70% occlusion, patients may not have any symptoms of angina. They still may have atherosclerosis, narrowing the lumen, but they will not have symptoms if they do some exercise. They start having anginal pain when it is more than 70% occlusion. When it is 70% occlusion, that leads to what we call stable angina. So these patients, they come to realize the extent of the exercise that caused chest pain in them. So they know it, and they will know the duration, like 10 to 15 minutes. And this pain disappears on rest. Disappears when they take nitroglycerin, that the medication that dilates the coronaries. But when there is rupture of this atherosclerotic plaque, as what happened in this case, this is the area of the rupture, then the dynamics of this changes. So the stable angina will change into unstable angina. Why? Because this rupture will lead to accumulation of blood, because platelets, they will spontaneously aggregate on any rough endothelial surface. Anytime there is a rupture or there is a change in this atherosclerotic plaque, that will be an invitation for platelets to accumulate, aggregate in that area, and then they attract red blood cells, fibrin, and then the clot takes place. So for a stable angina to change into unstable angina, something has to happen, like rupture of the atherosclerotic plaque. And as you see here, this is the plaque, this is the area of the rupture, and then the thrombus has formed in the already very much narrow lumen. And this changed the dynamics in this patient from stable angina to unstable angina, meaning that the duration of pain is more, and the pain is not relieved by rest, and also is not relieved by nitroglycerin. This makes unstable angina a reinfarction phase. So when patients, they come to the emergency, when this type of pain that is not relieved by rest or is not relieved by nitroglycerin, that could be a reinfarction. These patients are dealt with as having already an infarction, because the infarction will be very much, that can happen anytime in these patients. And here, this is a cut section through the heart. This is the free wall of the left ventricle. You can appreciate that the wall is very much hypertrophic. And this is an area of necrosis. So this is an acute infarct. This is an acute infarct. That's all what you need to know from this, that this is an area of an acute infarct, because there is no fibrosis. It's just a coagulative necrosis at this stage. Cut section through this will show you the presence of this neutrophil infiltration. This is very, very characteristic in myocardial infarctions in the first few days. By the end of the 7th day, the first week, then the fibroblast start laying down collagen, and then the coagulative necrosis will be transformed into a fibrotic scar that will stay permanently there. And here, that what you see is what we call it contraction bands. These contraction bands generally occur in areas when there is ischemic necrosis and the clot dissolves and there is reperfusion. So these contraction bands generally occur in areas of ischemic necrosis that have been reperfused. So these are the contraction bands. And if you look at these myofibrils, that you find that no nuclei, they are dead, means that ischemic necrosis has occurred in this area because of a shortage of blood supply. There is no blood supply to this area as a result of the clot. Now here we talk, this is one of the complications of myocardial infarction. And this is the rupture of the ventricular wall. Rupture of the ventricular wall is not that common. We will talk about the complications, which are, number one, arrhythmia. So please, if you are asked about the most common complication, it is not cardiogenic shock, it is not a rupture, it is not the aneurysm, it is arrhythmia. 75 to 80% of myocardial infarctions, the most common consequence of that is arrhythmia. The second is sudden death. Third, and this happens in about 20-25% of cases. Similarly, cardiogenic shock in about 15 to 20% of cases. Cardiogenic shock occurs if the ischemic area involves more than 40% of the heart muscle. If there is involvement of more than 40% of the left ventricular surface area, then cardiogenic shock occurs. Where there is poor contractility of the ventricle, therefore there will be hypoperfusion in the vital organs in the body, and there will be pooling of blood in the periphery, in the liver, and these patients, they will suffer from congestive heart failure, and that may be fatal. Other complications, the aneurysm, ventricular aneurysm can happen, and the rupture of the wall of the ventricle. The rupture of the wall of the ventricle occurs between the 4th and 7th day post-infarct. Happens after this time because of the weakening that occurs in the wall of the ventricle because of the coagulative necrosis. So the wall becomes thin, and under the pressure from the repeated contractions of the left ventricle, there a rupture may occur. Now, as you understand, rupture in the free wall of the ventricle will result in leaking of blood that can go into the pericardial sac, causing what we call hemopericardium, and this may also go on into, if there is a rupture or leakage from the pericardial sac, can go also into pleural space as well. So this is a complication that occurs between the 4th and the 7th day as a result of the weakening of the free wall from the ischemic necrosis that occurred at the time of infarction. This is just another histologic section to show you that the rupture occurs generally at the demarcation line between the ischemic part and the vital part of the ventricle wall. And this is, as you see, the fibrosis, that's coagulative necrosis, sorry, because it happens between the 4th and the 7th day. So this is the ischemic necrosis here. So this is the area of the infarction, and this is the vital part of the ventricle. Aneurysm, another complication. And this aneurysm is basically ballooning out of the free wall of the left ventricle. And this will result in turbulence in the blood flow. Anytime there is disruption in the nice flow of blood, that may lead to embolism. And sure enough, that these patients, they develop thrombosis and that end up having thromboemboli migrating with the bloodstream to other areas of the body, mainly the brain. Now this graph is about a patient not with myocardial infarction, a patient that has been taking alcohol, and this patient developed acidosis, developed dark urine, dilation of the pupils. And as you see, that the CK index that is never more than 4. So this goes with rhabdomyolysis, and as we know that alcohol is a major cause for rhabdomyolysis. Similarly, cocaine is another cause. Statin drugs, medications, that cholesterol, anti-cholesterol medications are cause of rhabdomyolysis. Crush injuries, another cause of rhabdomyolysis. Extreme elevation of temperature. Patients that they develop temperatures in the range of 105, 106, they may develop rhabdomyolysis. So what basically happens, that there will be release of the myoglobin. This is a protein that causes dark color of the urine, cause the urine to become red, dark red. So as you see here, that the CK, that will be very high in these patients because the CK present in the skeletal muscle. That's why it is very, very high. But as I told you, that the CK index is the equation of the CKMB divided by the total CK. So 6/6,000 multiplied by 1,000 will give you a CK index of 1. We go to the next case. And the next case is about a 70-year-old male. And here, as you see, that this is the aortic valve. And these are the 3 leaflets of the aortic valve. And as you see that there is calcification. So this calcification is due to aging. So it is a degenerative type of a process. So this is degenerative calcific aortic stenosis. So because of the deposition of the calcium, that the lumen becomes very narrow, and these patients, they may end up having aortic stenosis. And when they have aortic stenosis, as you know, then in this case, that the left ventricle will be contracting against resistance, and that will lead to what we call it concentric hypertrophy of the left ventricle. So please, when we talk about left ventricular hypertrophy, there is a significant implication when we say asymmetric and symmetric or concentric. So when the hypertrophy is concentric, it happens in 3 conditions: in hypertension, in aortic stenosis, and in coarctation of the aorta. So please remember these conditions in which concentric hypertrophy of the left ventricle. So this is one of the conditions. Now what happened in these patients, that you find that there is aortic stenosis. So there is very high resistance, and therefore the pressure gradient before the valve and after the valve is big difference. And therefore that this will reflect on the filling of the coronary arteries, because with this sudden lowering of the pressure beyond the aortic stenosis will not give chance for good filling of blood to the coronaries, and therefore that these patients that they will have ischemic attacks. Plus, what worsens these ischemic attacks, not only because of this pressure, sudden lowering of the pressure, the second thing that because of the fact that these patients have developed concentric hypertrophy of the left ventricle, this means that there is an increased blood demand which the heart cannot supply. So this is another, negative side effect that worsen the situation because of the increased demand for blood by the hypertrophic muscles of the left ventricle. So you can appreciate, so when we talk about concentric hypertrophy, meaning that the thickness of the free wall is equal to the thickness of the septum. And this is the aortic valve, which is stenotic, and the resistance of pushing blood through the aortic valve leads to hypertrophy of the left ventricle. Another condition that leads to calcification of the aortic valves, the bicuspid aortic valves. This is the most congenital anomaly of the heart, bicuspid aortic valves. And because of this disparity across these leaflets, because one is shorter than the other, that sort of expedite calcification of these leaflets. So in this case, it is dystrophic calcification of the aorta, but also it leads to the same result, that these patients, they end up having aortic stenosis and they will have ischemic, pain because of the stenosis that's occurring at the aortic valve, leading to sudden drop of pressure that is not enough to fill the coronaries of the heart, particularly that there is increased demand now for blood as a result of the hypertrophy. So please differentiate between the degenerative calcific aortic stenosis in elderly patients and the dystrophic calcifications in patients with bicuspid aortic valves. And since we are in this picture here, please appreciate before we go to a similar picture when we talk about rheumatic heart disease, that when you look at the commissures here, at the end of these, the origin of these leaflets, they are not fused because this process is a degenerative process. It's not an inflammatory process. But when I show you the same aortic valve, in those cases of rheumatic heart disease, you will see the fusion of the commissures in that image because of the inflammatory process. So these patients will end up needing surgery to correct the stenosis. So here we are talking about the artificial valves. So the artificial valves can be mechanical valves or they can be biosynthetic valves. And this is the thrombus that's occurring. This is one of the struts of the valve, and this is the thrombus. So as you know, that these artificial valves, they are basically a foreign body, and that is not the normal surface endothelium. Here, the blood is passing along a foreign substance, basically, so that there is every risk for thrombosis. That's why these patients, they are immediately put on blood thinners to prevent thrombosis. What are the advantages and disadvantages of these valves in comparison between the mechanical and the biosynthetic. The mechanical valves, they are more durable than the biosynthetic valves. About 30% of the biosynthetic valves, they fail within 10-year period, but these are more durable. However, these mechanical valves result in destruction of red blood cells. So there may be free hemoglobin that is circulating in the blood. And as you know, anytime that you have free hemoglobin, that you'll find that the protein that will combine with the free hemoglobin is haptoglobin. So haptoglobin generally is the protein that will combine with hemoglobin once that it is released from these red blood cells. And that can be a test that you do to confirm if there is intravascular hemolysis, that you check for the level of haptoglobin.
Dr. Ramadan?
Yes, sir.
So when you talked about the 30% of biosynthetic valves failing within 10 years, does that mean that you would most likely give those types of valve replacements to like elderly people? Because if it fails,
Absolutely. It's a very nice point. Absolutely, sir.
Got it. Thank you.
Yes, because, patients, in their 70s, that, the prolonged life, the span of life. So, yes, we prefer, to give them. This is a very, very good point. Absolutely.
Got it. Thank you.
Absolutely. So the fourth case, so here that we're showing you a kidney. And if you look at the kidney, that this is the normal, not the normal external surface of the kidney. The surface of the kidney should be smooth, but here, if you look at this, that you find that it is pitted and it is sort of scarred. So the pitting here on the external surface of the kidney represents that ischemic necrosis as a result of these microinfarcts that occur in the small arteries and arterioles of this kidney as a result of hypertension. So this is the cut section through the kidney, and you can appreciate these small arteries and arterioles where there is very much thickened wall leading to a narrow lumen. This is what we call hyaline arteriosclerosis. Hyaline arteriosclerosis occurs in patients with long-standing hypertension. Patients with, patients with essential hypertension. So you find this hyaline arteriosclerosis. What is this hyaline material? This hyaline material is a protein that is thought or believed to have been leaked out from the endothelial surface, get deposited in the wall of these blood vessels as a result of this elevated blood pressure over the years. And this is the glomerulus here that has sclerosed as a result of ischemia. So when you have these hyaline arteriosclerosis, this occurs in patients with hypertension, occurs in patients with diabetes, and even otherwise can occur as a result of aging. So I find that if there is aging plus these other factors, diabetes or hypertension, that will lead to sclerosis and atrophy of these glomeruli all over the kidney, and that will end up resulting in kidney failure, failure of these patients. So please differentiate this image from the next image when we talk about malignant hypertension. So here we are talking about hyaline arteriosclerosis. So this is here the thickening of the intima and the media of these small blood vessels, leading to narrowing of the lumen, and that with time will lead to kidney failure. This here too showing you a normal heart compared to a hypertrophic heart. And this is compressed right ventricle. So this is the septum and this is the free wall, and this is concentric hypertrophy. And we talked about the different conditions that result in concentric hypertrophy, which is hypertension, aortic stenosis, coarctation of the aorta. Here we come to an important condition, which is aortic dissection. Aortic dissection occurs. There are first two types, type A and type B. Type A that involves the proximal part of the aorta, which is basically the ascending aorta and the arch of the aorta. And this is the most common type, which is type A. So it involves the ascending and the arch of the aorta, and this is the most common. And this is type B, which is involving the distal part of the aortic arch and the rest of the aorta. So what happened in these cases? The classic example of aortic dissection is the aortic dissection in patients with Marfan syndrome. As you know that patients with Marfan syndrome, this is an autosomal condition and characterized by mutation in the gene that produces the fibrillin protein. Fibrillin normally, that this is a glycoprotein that forms fibrillary aggregates in the extracellular matrix to act as the scaffolding for the elastic layer to rest on it. And that will ensure elasticity of the aortic wall, so that the wall will be very flexible, because it is, the aorta is a major vessel where there is high pressure. So you need a wall that is very elastic, very flexible, that can expand and go back to normal in a very flexible manner. But in these patients, because of this abnormality of the fibrillin protein, due to the mutation of the gene on chromosome 15, so this fibrillin now does not form that nice scaffolding for the elastin to lie on top of that to ensure the elasticity and the flexibility of the wall of the aorta. So you find that the aortic wall in this case is very weak. It is very weakened, and it undergoes necrosis, and you find that it's very easy for the media to rupture. So you find through this rupture that occurs that there will be a leakage of blood that goes between the adventitia and the intima into involving the medial layer. And this is the types of the aortic dissection. And here that you find that this is the wall of the aorta, showing you that this is the areas of necrosis because of lack of the fibrillin that forms this very nice scaffolding for the elastic layer. So that here, this is what is called medial cystic necrosis, medial cystic necrosis that occurs in the wall of the aorta in patients with Marfan due to abnormal fibrillin protein that does not form the scaffolding for the elastic layer to build on. And you can appreciate here that this is the elastic fibers. And as you see that they are fragmented, they are supposed to be, arranged in very nice layers parallel to each other to maintain that elasticity. but here because of the lack of the scaffolding of the fibrillin protein, that they are fragmented, and many areas they are necrosed, as you see here, and fibrosed as well. So that these areas become at increased risk for rupture anytime. So this is the normal. You find that this is the elastic layers that the elastin is laid on top of the fibrillar aggregates, and makes this very nice weave that makes the aortic wall very resistant to pressure. On the other hand, we have the aortic aneurysm that occurs as a result of complications in atherosclerotic plaques. The abdominal aorta is a very common site for atherosclerosis. And that depends now on other conditions in these patients, so whether they are diabetic, they are hypertensive, they are hyperlipidemic, where cholesterol is high. So the atherosclerosis will depend on these factors. So if there are so many risk factors for that, you find that the atherosclerosis build up early in this area, particularly the area below the origin of the kidney branches from the aorta. So this is the normal location of the abdominal aortic aneurysm, which is below the origin of the renal branches. The aneurysm is a fusiform in shape, and this is the thrombus that has developed in this. So anytime that there is severe atherosclerosis, the atherosclerotic plaque may rupture, and that will be an invitation for a clot formation that can occur. Now, the aneurysm size is very important. There is a cutoff point that you don't need to know that for the lab exam, but you may need for the board. I think the cutoff point is about 5.5 centimeter. Correct me if I am wrong. And that at that point, that surgery is very much indicated, should be done, because beyond that point, rupture of this aneurysm can happen anytime, and this is a very fatal condition. Many patients, when rupture of abdominal aneurysm occurs, more than 50%, they don't even reach the medical centers. They die before they reach medical centers because the leakage of blood, the bleeding is very intense, and a lot of blood is lost before the patient can be taken care of. But that's why that these patients, when they have abdominal aneurysm, that they are followed regularly to make sure that the size does not reach that serious level. And when it is about to reach that, then surgery will be done before the complication of rupture. Because to do surgery on still intact aneurysm, much easier than doing it as an emergency. And here that you remember that when we talked about the hyaline arteriosclerosis, and this is what we call it hyperplastic arteriosclerosis. Compared to that hyaline arteriosclerosis there, that was due to leakage of fibrin, leakage of the hyaline material that deposits on the endothelial surface. So that is the hyaline arteriosclerosis there due to damage to the endothelial surface because of long-standing hypertension there. And that is a gradual process. So here is different. Here the blood pressure is called a malignant hypertension. Very high blood pressure. And as a result of this high level of pressure that induce this hyperplasia and hypertrophy of these smooth cells in the intima and the media. So there is hyperplasia of the smooth muscle cells that lead to these concentric rings, as you see. in the intima and in the media, resulting in very narrowing of the lumen of these small arteries and arterioles. So this, please remember, it is hyperplastic change, whereas that was a hyaline arteriosclerosis due to deposition of hyaline material on the walls of these blood vessels, causing the thickening there. But here, the thickening is because of the hyperplasia and hypertrophy of the smooth muscle cells and the intima and the media as a result of malignant hypertension. So when you look at this image, then you can imagine the total picture of this type of patient. So with this image, with your understanding that this can only occur in patients with malignant hypertension, meaning that this patient is at increased risk for intracranial hemorrhage. This patient is at risk for concentric hypertrophy of the left ventricle. This patient is at risk for sudden death. So that you can build the story based on this image, realizing that this patient is having a high blood pressure. And this is the fibrinoid necrosis. This is fibrinoid necrosis, so please connect this fibrinoid necrosis with the previous image here, this one, that as hyperplastic arteriosclerosis, which is because of malignant hypertension. And this is to emphasize to you as one of the complications in patients with malignant hypertension that they may have intracranial hemorrhage. Now we come to another case, and here we are discussing about a rheumatic fever, acute rheumatic heart disease, and chronic rheumatic heart disease. So this is a patient. Now, when we talk about rheumatic fever, immediately we understand that this first type of hypersensitivity reaction that has resulted in patients infected with streptococcal bacteria, streptococcal pyogenes. And this bacteria, so there is a history of pharyngitis with this type of bacteria. So how is the explanation for this hypersensitivity type of reaction? The explanation is this. So this bacteria has an M protein in its structure for which antibodies are formed in the body. These antibodies, which are basically made against the M protein of the bacteria, they end up cross-reacting with a similar protein in the heart. So that results in this hypersensitivity type of reaction. What is the time sequence? The time sequence, now the initial event is either pharyngitis or skin infection. So pharyngitis occurs today, then a minimum of 3 weeks later, then these patients, they may come back with fever and all the criteria that we will talk about. So it does not happen immediately. So the condition of the initial pharyngitis may be totally resolved. And then the patient, they come 4 weeks later, 5 weeks later, coming down with the acute rheumatic fever. What is the criteria now of acute rheumatic fever? The criteria for diagnosis is either two major criteria, or one major and two minor. Now, when we talk about the major criteria for the acute rheumatic fever, we are talking about, number one, the pancarditis. We talk about pancarditis. We talk about polyarthritis. We're talking about erythema marginatum, subcutaneous nodules, and chorea. So these are the major criteria for the acute rheumatic fever. And when we talk about the minor criteria for the acute rheumatic fever, then we are talking about patients coming with fever, arthralgia, previous history of rheumatic fever or rheumatic heart disease, elevated erythrocyte sedimentation rate, positive C-reactive protein, or prolonged PR interval on the EKG, and positive streptolysin O titer. So this is the, what we call it, Jones criteria for acute rheumatic fever. In this image now, it is showing you the pancarditis, meaning all the three layers of the wall of the heart, the endocardium, the myocardium, and the pericardium. The involvement of the pericardium in the form of vegetations along the line of the closure of the leaflets, the origin of the leaflets. And in the myocardium will be the ash of bodies, which I will show you. And in the pericardium, in the form of pericarditis, fibrinous or fibrinous pericarditis. Here, showing you the myocardium. So the myocardium, we see the typical, the hallmark of myocarditis in acute rheumatic fever, which is the ash of bodies. And this is the ash of giant cells. Basically, these ash of bodies, basically they are granulomas. Please remember, they are basically granulomas, where you find that there is infiltration of lymphocytes, plasma cells, macrophages, and in the center that you may see fibrinoid necrosis. So ash of bodies, they are granulomas that they develop in the myocardium as a result of this hypersensitivity type of reaction. Then we talk about the complications that occur with time. So the acute rheumatic fever, we mentioned that there will be vegetations. The vegetations, they will form on the leaflets of the mitral valve and other valves, but most commonly it is the mitral valve in about 70 to 80% of the cases. It is the mitral valve. These vegetations with time, they will lead to scarring and fibrosis of the mitral leaflets, resulting in mitral stenosis. And this will be elicited by a stethoscope when you listen to the chest of these patients, to the heart of these patients, to find a mid-diastolic murmur. So there will be a diastolic murmur. This complication of rheumatic heart disease is more common in females than males, in the ratio of 2 to 1, 2 females to 1 male. So what we see here, mitral stenosis, and anytime that there is stenosis, you would expect resistance against the flow of blood. You know that the blood will flow from the left atrium to the left ventricle through a mitral valve. This flow is facilitated by contractions of the left atrium. So since the left atrium will be contracting against resistance, then there will be left atrial hypertrophy and dilatation. And this is what has occurred in this left atrium. And anytime that there is dilatation, there will be turbulence of blood, and that may lead to thrombus formation, as you see here. And anytime that there is thrombus formation in the left atrium, you can expect that any fragmentation in this thrombus may travel in the bloodstream and can go to the brain and cause a blockage of some of these vessels in the brain. These patients are also at increased risk for what we call atrial fibrillation. because of the hypertrophy of the left atrium. And this is a cut section showing you in a chronic rheumatic heart disease that this patient will, now this happens in the third decade, patients in their 20s, in their early 30s, they may come back now having these problems, shortness of breath, having problems with cough, and the cough sometimes is tinged with blood, the sputum is mixed with blood or smeared with blood. And I'll explain to you why. So they complain of shortness of breath. They cannot do exercise. These patients, because there is no enough blood that is going through the mitral valve to the left ventricle and to the rest of the body. So what that will lead to. So whenever there is a resistance, there will be increase in the hydrostatic pressure. This hydrostatic pressure will travel back through the pulmonary vein, and the hydrostatic pressure in the pulmonary vein will still transmit back to these small capillaries in the lung, causing rupture of these small capillaries, leading to leakage of red blood cells outside these capillaries, leading to congestion of the septum between the alveolar spaces. And there'll be also oozing of fluids, resulting in pulmonary edema, oozing of red blood cells, rupture of these blood cells releasing hemoglobin. Hemoglobin, when it is exposed to oxygen, will be transformed to hemosiderin, and then macrophages will come to engulf hemosiderin, and there will be the formation of heart failure cells. So this is a chronic rheumatic heart disease characterized by thick fibrosis of the leaflets. Similarly, there is thick fibrosis of the chordiotendineae, as you see in this image. And this is what happens. This fusion in the commissures that I drew your attention to when we looked at that degenerative calcific aortic stenosis in that 70-year-old patient. But here now we are talking about the aortic leaflets in patient with rheumatic heart disease. So this fusion of the commissures is the result of an inflammatory process. And it leads to the same result, which is aortic stenosis. So this is the stenosis that has resulted from the fusion of these commissures. So this is here a heart that has developed both mitral stenosis and aortic stenosis. And you can see the consequences of this. Because of the mitral stenosis here, you can appreciate the left atrial dilation. And because of the aortic stenosis, you can appreciate the concentric hypertrophy, as you see here. So this patient, now you can build the story that this patient is at risk for atrial fibrillation. This patient is at risk for pulmonary edema. This patient is at risk for concentric hypertrophy. This patient is at risk for congestive heart failure. All these complications you can build up in your mind by looking at this image. And this is here the picture from the lung about the septum between alveolar spaces, and you can appreciate that it is congested. That's the red color here, indicating congestion. And you can see these heart failure cells, which are basically macrophages filled with hemosiderin. So this cannot be an acute condition. So this is a chronic venous congestion in the lung. Why chronic? Because of the presence of the heart failure cells. If it is acute, you should not see these heart failure cells. Since we were talking about vegetations in the rheumatic heart disease, then we further discuss about other types of vegetations. So vegetations form in the valve leaflets in the heart in patients with rheumatic fever, in patients with infective endocarditis, in patients with non-bacterial thrombotic endocarditis, like in patients with cancer or patients with systemic lupus. And this will lead us to be able to differentiate between the type of vegetations that are result of infection or vegetations that are result of cancer or autoimmune diseases. So the vegetations that are a result of infection, they are generally large vegetations, and they cause destruction of the valves. So this valve is the tricuspid valve. Most likely, this patient is an IV drug abuser, and these vegetations developed on the leaflets of the tricuspid valve because it is the first valve that come in contact with this contaminated blood because of the use of unsterile needles in these patients. So here when you have these vegetations on the tricuspid valve, they may go to the lung, cause lung abscess, but please be aware that they may go to the brain, and that paradoxical type of thrombus, and that happens in cases where there is ventricular septal defect. Whenever there is ventricular septal defect, so these vegetations may travel from the right side of the heart, bypass the lung, and go to the left side of the heart, to the left ventricle, and carried by the blood to go to the brain. So it's not impossible for these vegetations to go to the brain, particularly in a patient with ventricular septal defect or atrial septal defect. So here showing you the bacterial endocarditis. This is the leaflet between the atrium and the ventricle. And this is the vegetation here in the atrium, the vegetation here in the ventricle. And this is the line represents the presence of the bacteria. And this also on the wall of the ventricle representing the abscess that is forming as a result of this bacterial endocarditis. Now, you need to know the different types of bacteria that can cause endocarditis. If the valves are intact, they are healthy, they are not previously damaged, then the type of the bacteria has to be with high virulence. Then the type of bacteria that can cause bacterial endocarditis of healthy, normal heart valves, Staphylococcus aureus. If endocarditis occurs in a patient with valves that are damaged previously by rheumatic heart disease, the most common bacteria is Streptococcus viridans. If endocarditis, bacterial endocarditis occurs in a patient with colon cancer, then most likely the bacteria will be Streptococcus bovis. If this happens in a patient with abdominal abscess, then most likely it is Streptococcus faecalis. If this happens in a patient with diabetes, then most likely it will be either gram-negative bacteria, Klebsiella, or Pseudomonas, or it will be a type of fungus. So here that it depends on the scenario, the clinical scenario that you are given, and that will be the type of the bacteria that causes the bacterial endocarditis. So here this section showing you the section through the vegetation. This is the colonies of the bacteria surrounded by fibrin, and these are the inflammatory cells here, which are basically the neutrophils. On the other hand, we have the vegetations that are non-bacterial vegetations. So these vegetations, as I told you, they can happen in patients with cancer, particularly those cancers that they release certain substances that are procoagulant. They cause coagulation, they cause hyperviscosity, and the classic cancer in this regard is pancreatic cancers. Other causes of non-bacterial vegetations is autoimmune diseases, particularly systemic lupus erythematosus. And the vegetations in this condition is called Lehmann-Sachs disease. Lehmann-Sachs disease, the vegetations that are present on the leaflets in patients with lupus, they can be seen above the leaflets. They can be seen also below the leaflets in both surfaces. The characteristic thing about these vegetations, the non-bacterial vegetations, they are loosely attached to these leaflets, meaning it's very easy for these vegetations to detach and go to block vessels somewhere else, like in the brain. The next case is about myocardial hypertrophy. We're talking about myocardial hypertrophy when we talked about the concentric hypertrophy in the left ventricle because of hypertension, where you find that the septum thickness is equal to the free wall thickness. But here we are talking about a condition in which that it is asymmetric hypertrophy. This is a condition that is happening as a hereditary type of condition, autosomal dominant, in which these patients that may be at risk of sudden death when they attempt to do some sort of exertion, like lifting weights or participating in a soccer game or that sports that demand big efforts. So why? Because the hearts in these individuals, that they are not capable of supplying good cardiac output. The reason is, as you see here in this case. So because of this hypertrophy of the left ventricle, and you see that the bulge of this septum is encroaching on the lumen of the left ventricle, leaving very little space for blood to come in during diastole. So here there is very little blood that is present in the left ventricle. And despite the good force of contraction because of the thickness of the muscles of the left ventricle, but the cardiac output is very low. So here it is a diastolic dysfunction in these patients. The typical history about these patients, they have recurrent syncopal attacks because of hypoperfusion, low amount of blood reaching the brain. So these patients, they may complain of these syncopal attacks, of shortness of breath, of dyspnea, and not surprising if they are stated to have undergone sudden death because at the time that the typical scenario that they give you about these patients, that no sooner that the soccer game started and so dropped dead. That's the reason, because this left ventricle cannot supply enough blood to maintain the increased demand on the heart because of the exercise. So it is a diastolic dysfunction. It's autosomal dominant, and it is affecting the gene in the myosin B protein that's present in the heart muscles, myosin B protein, autosomal dominant. This is another section, but putting it the other way around. So this is here in this area, that this is on the left side, that you see the free wall of the left ventricle, and you see here the septum, and you can appreciate the bulge, the septum that is encroaching on the ventricular lumen. And also that because of this bulge, that it obstructs the flow of blood into the aortic valve. You can appreciate that this narrow passage here. So this aggravates the situation is still worse. And please keep in mind the buzzword about disarray. this area. This is always the buzzword that's given to you in the board questions, in questions about this hypertrophic myocardium in these patients. This area arrangement of the bundles of the muscles of the heart. And here showing you comparison between different types of cardiomyopathy. So this is a normal heart, and this is the hypertrophic cardiomyopathy, and this is the dilatory cardiomyopathy, dilated cardiomyopathy. And when we talk about the dilated cardiomyopathy, I want you to know that this here is a systolic dysfunction. Systolic dysfunction, because these hearts, they cannot contract with force. The wall is very much weakened, and therefore that there is the cardiac output is very small because of poor contractility in these patients. Now, what are the different conditions or the different causes that can lead to dilated cardiomyopathy? So I want you to please remember that A, B, C, 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 D. A for alcohol, B for beriberi, C for cocaine, another C for Kawasaki virus, the other C for Chagas disease, and D for doxorubicin. So this is the A, B, C, 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 D that are the causes of dilated cardiomyopathy. So 30 to 50% of these cases, they are genetic, and the remainder of these cases, they are non-genetic. So, but please remember that here, that in this case, that the ventricles, they are dilated and they are flabby with very poor contraction. And these patients will suffer from progressive congestive heart failure, and they have very low ventricular ejection fraction, and these patients, they are at increased risk for sudden death. This is from an infant, so this is dilated cardiomyopathy, and this, in this case, the cause is Coxsackie B virus, and it is one of the causes of dilated cardiomyopathy, and this is a fatal condition. And anytime, as you know, we are talking about viral infection, we talk about lymphocytic infiltration into the heart muscle. And the common locations for lymphocytic infiltration is perivascular, as you see here. So this is from the heart of this infant, this lymphocytic infiltration to indicate that this is a Coxsackie B viral infection that has led to dilated cardiomyopathy and death of this infant. The pericardium of the heart, and this is from a patient with AIDS that secondarily was infected with tuberculosis, because these patients with AIDS, they have decreased resistance and they become very susceptible to infections with tuberculosis. And this is evident that because of the initially when AIDS started in this country, at that time there were a very, very low number of tuberculosis cases, but with the increased cases of AIDS, that tuberculosis cases, they rose significantly because of this weakened resistance, immune suppression that occurs in these patients and leads to flare up of tuberculosis cases in this country. So when we talked about the types of cardiomyopathy, we talked about hypertrophic cardiomyopathy, and we explained the causes for that. So we talked about dilated cardiomyopathy, and now we are talking about restrictive cardiomyopathy. So when we talk about restrictive cardiomyopathy, we talked about infiltration in the muscle of the left ventricle or in the heart in general by certain proteins or certain substances like iron or copper. And so the classic examples for that, amyloidosis. As you know, that amyloidosis is a type of protein that develops either primarily or develops secondarily. So in this case, the amyloidosis is secondary to a patient with multiple myeloma. So please be aware that amyloidosis occurs in about 25% of multiple myeloma cases. What is multiple myeloma? Multiple myeloma is a cancer of plasma cells. Plasma cells, these are the mature form of B lymphocytes. Plasma cells, they are mature B lymphocytes. Their function is to make antibodies, which are the immunoglobulins or the gamma globulins. And as you know, anytime we talk about cancer, we say it is monoclonal cell, that it is one monoclonal cell that become cancerous, and from that cell, all the cancer cells, they develop. So when we talk about multiple myeloma, then we talk about monoclonal gammopathy, meaning that this monoclonal plasma cell will lead to production of only one type of immunoglobulin. It is either IgA or IgG. So it's one monoclonal type of gamma globulins. So these gamma globulins, they have heavy chain and they have light chain. And you know the light chains, that are kappa and lambda. The other name for light chains, Bence-Jones proteins. And these Bence-Jones proteins, they are very injurious to the kidney tissue. So generally these patients with multiple myeloma, they die of kidney failure or infection. Since this cancer of multiple myeloma is basically a cancer due to excessive increase, enormous increase in the numbers of plasma cells in the bone marrow. So because of that, the bone marrow is producing large amounts of plasma cells to the extent that it is causing thickening of the cortex of the bone. And that results in what we call it punched out lesions. Why I am going into all this detail? To make you aware that in a clinical scenario, if they give you a clinical scenario about punched out lesions, about monoclonal gammopathy, about Bence-Jones proteins, about monoclonal spike in the serum protein electrophoresis, which is the test that is done to test for the presence of these monoclonal type of proteins, to be aware that they are trying to draw your attention that they are talking about this scenario, a scenario of multiple myeloma, and they expect you to know that if we are talking about restrictive cardiomyopathy, then the possibility that in this patient, amyloidosis might have happened secondarily as a result of this monoclonal gammopathy, which causes the restrictive cardiomyopathy in this case. So since we are talking about amyloidosis, I want you anytime that we talk about amyloidosis to remember that if you do the routine stains, the hematoxylin and eosin stains, we call it H and E stains, for these pathology sections to make glass slides and look at the pathology through the microscope. These traditional stains, H and E stains, they will not stain the amyloidosis, will not stain the amyloid protein. We need a special stain for the amyloid protein, and that special stain, Congo red. Please don't forget the special stain for amyloidosis is Congo red. This is one thing. So when you take a section and you put it in a glass slide and look at that glass slide through the microscope, after you stain it with Congo red, it will highlight the amyloid proteins in the form of this red color. Another test to highlight the presence of amyloidosis in the muscles of the heart is what we call it apple green birefringence, apple green birefringence. So when you look through the microscope using a polarized lens will give you this type of birefringence, the apple green, that this is a confirmatory test for the presence of amyloid protein in these organs. So when we talk about restrictive cardiomyopathy, so it's not only amyloidosis, sarcoidosis can cause the same thing, hemochromatosis, which is basically increased iron in the blood, and therefore there will be iron deposited in the organs, in the heart, in the liver. So deposition of iron particles in the heart will lead to restrictive cardiomyopathy as well. There is also a condition called Wilson disease. In Wilson disease, there is increased copper deposited in these organs. So again, that can lead to restrictive cardiomyopathy. In this case, case number 6, we're talking about non-cyanotic congenital heart disease. So here we have a baby, 2-month-old baby, and we see that this is the probe through the left ventricle and right through the septum, as a matter of fact, and this is the ventricular septal defect. What you need to know about ventricular septal defect. It's a very, very common congenital anomaly of the heart. Number one. Second, 50% of these defects, if they are small, they close spontaneously, so nothing need to be done. They don't cause any damage, they don't cause any problem, and the murmur will disappear and the defect will spontaneously close. For those that they are large, then they will not close and they may need surgery to correct the defect. Now, for those that they are large, what are the complications? The complications is about the shunt, the direction of the shunt of the blood. Initially, the direction of the shunt of the blood will be from the compartment with high pressure to the compartment with lower pressure. And the compartment with higher pressure is the left ventricle. So it will go from the left ventricle because there is the systemic circulation, so you need a lot of pressure to push blood to the rest of the body through the aorta. So it has high pressure. So the blood will move initially from the left side to the right side. Now, increasing the pressure over time in the right side, in the lungs, will lead to the development of what we call pulmonary hypertension. In that case, the pulmonary hypertension pressure may become 2 or 3 times higher than the pressure on the left side, and there will be a reversal of the shunt. So that you need to understand about the direction of the shunt. The location of these ventricular septal defects, 90% of these cases, they are located in the membranous part of the septum. The septum between the ventricles composed of membranous part and muscular part. These defects, 90% of the time, develop in the membranous part of the septum. So here, just emphasizing to you that this is a large ventricular septal defect that has led to hypertrophy with time, because now when you're talking about, that you have to push blood against resistance over a period of time will lead to hypertrophy as well. And this is schematic representation showing you that this is the left side of the heart, oxygenated blood that moves from the left to the right, and the blood is oxygenated going into the right ventricle, going back to the lung. And this is here in this image explaining to you how pulmonary hypertension develops. So when we are talking about the left to right shunt, so with time that you are increasing the blood volume all the time on the pulmonary side, so that the pulmonary system now will contract against resistance. So with time, there will be hypertrophy of the smooth muscles in the intima and in the media resulting in this type of picture, narrowing of the lumen and thickening of the intima and the media. And this is highlighted to you by the presence of this elastic layer that's supposed to be here and it is pushed all the way here because of expansion of due to the thickening of the media in this case here. So you can appreciate it. The hypertrophy and hyperplasia of these smooth muscles leading to the narrowing, and that results now in pulmonary hypertension that may reverse the shunt. Now here they're showing you atrial septal defect. This is primum and this is secundum. And this is to tell you, though they also may result in left to right shunt, but definitely will not lead to that degree of pulmonary hypertension as much as in case of ventricular septal defect. That's the theme of this image. And here we are talking about another congenital defect, the patent ductus arteriosus. As you know, that this is a normal anatomy in fetal life, where the blood in fetal life will move from the right side, from the right ventricle, through the patent ductus to the aorta. And then the aorta will carry the blood to the rest of the body, and then the aorta will supply the upper part of the aorta. If you look at the fetal circulation that generally we are talking about, in the fetal circulation, it is the umbilical artery that takes the blood to the placenta. And the umbilical veins, they bring the oxygenated blood back to the fetus, initially to the liver, and from the liver to the inferior vena cava, goes to the right atrium, and the right atrium, from the right atrium to the left atrium through the foramen ovale, and then from the left atrium to the left ventricle to the aorta, and this highly oxygenated blood will go by the aorta, will go to the brain and the upper part of the body, because it has high oxygen that gives oxygen to the brain of the fetus. So the blood coming back from the fetal body enters the superior vena cava, that after going to the brain and the head, that comes back with the superior vena cava, that comes back to the right atrium, from the right atrium to the right ventricle. Then the right ventricle here in this case will go through the pulmonary artery, and the pulmonary artery through the ductus, patent ductus, that will send it into the lower part of the aorta, and the aorta will take the blood back to the placenta. So this is normal in the fetus. Now, normally this ductus closes in the first or second day after birth. What happens in premature children, it stays open, or even in mature children, it may still stay open. And in that case, there will be reversal of the shunt. So the shunt will be from the left side to the right side, unlike the shunting in case of the fetal life. So when we talk about patent ductus arteriosus, I want you to be aware that sometimes that this is needed in patients with cyanotic heart disease, because it will be the only source of oxygenated blood in these patients and can sustain life for some time until surgery is done. Another thing that I want you to know about patent ductus arteriosus, that if they ask you about any time you hear the phrase machinery murmur, that basically they are talking about patent ductus arteriosus because it has both components, systolic and diastolic. And the last case that we'll talk here about the cyanotic heart diseases. And cyanotic heart diseases, we talk about 3 conditions. Number 1 is tetralogy of Fallot. And from the name tetralogy meaning 4 defects. First is the VSD. Second, overriding of the aorta. Third, hypertrophy of the left ventricle. Fourth, pulmonary stenosis. So this cyanotic heart disease, the very typical scenario that they will tell you that an infant born with a bluish tinge of the face, dark, this bluish discoloration intensifies when the child breastfed and the child is restless, all this stuff. So,
Dr. Ramadan?
yes, please.
I thought it was right ventricular hypertrophy.
Yes.
Oh,
Yes.
okay.
Did I say left?
Yeah, I think so.
Okay, I'm sorry. Yeah, this is the right ventricle, of course. Yeah, this is the right ventricle and the pulmonary vein that, I mean, this the stenosis, the pulmonary artery that that is stenosed here. So this is the stenosis. And this is the right ventricle, and this is the hypertrophy of the right ventricle, absolutely. And this is the left ventricle, because the aorta is rising from the left ventricle, as you see. All right, so this is an example of congenital heart disease. And remember these 4 things. Remember about cyanosis. Remember about restlessness with the child. Remember that's worse when these children breastfed, and it has to be corrected. And you can appreciate that this is the patent ductus arteriosus here in this case. As you see, that can help sort of send some oxygenated blood with the left to right shunt. The other condition is the transposition of great vessels, where you find the aorta is arising from the right ventricle, and you find that the pulmonary artery that is arising from the left ventricle. And again, that this is a very serious congenital disease. It is not compatible with life and needs to have VSD to sustain life, or patent ductus arteriosus, you have to sustain life until surgery is done. And the third condition is coarctation of aorta. And in coarctation of the aorta, it has 2 types. One type is pre-ductal coarctation. This happens in 70% of cases. This is commonly occurs in children, and it is associated with cyanosis. So please remember that this is associated with cyanosis. On the other hand, the post-ductal, that you find that the constriction is beyond or distal to the duct. Therefore, you find that there is very high pressure in the blood vessels above, in the upper part of the body, in the neck and head, and there will be very low pressure in the rest of the body. That's why you find that there's unequal pulse. Generally, in both conditions, there is unequal pulse. So please remember that there's unequal pulse between the upper limbs and the lower limbs. In case of preductal, there is an added factor, the cyanosis. But in the postductal, we are talking about rib notching, because of the development of collaterals, because of this difference in pressure between before the duct and distal to the duct. Rib notching that occurs in these adults due to the post-ductal coarctation. Another thing that you need to know about this is its association with Turner syndrome. So please remember that coarctation of the aorta can be associated with Turner syndrome. And you know the Turner syndrome, that is the 45X chromosome. So here they're showing you the difference in thickness between a normal artery and the carotid artery where there's increased thickness, and this is the lumen. So please remember, anytime that we are talking about cartilage in the aorta, we are talking about cyanosis in the preductal, we are talking about rib notching in the postductal, we are talking about association with Turner syndrome, we are talking about delayed pulse, we are talking about cyanosis. So please differentiate between when we say delayed pulse or there is absence of pulses in the lower limbs. When there is a rupture of the abdominal aortic aneurysm, there will be absence of pulses in these lower limbs. If you feel for pulse in the femoral artery or posterior tibial artery, that you will not feel the pulse. So please differentiate when we say that there is unequal pulses between the upper limbs and the lower limbs, and when we say absent pulses in the lower limbs. Absence, total absence pulses that can be seen in patients with ruptured abdominal aortic aneurysm. And when we talk about one point that I want to add, which may not be needed for pathology small group, but you may need it for the board, about squatting. Yes, when we talked about the pathology of Fallot and these children, they resort to squatting because that, in a way, compensatory mechanism that relieves some of the hypoxia that these children they have, because it sort of decreases the shunting across the ventricular septal defect because of elevating the aortic resistance. So there will be decreased of shunting and there will be more flow of blood through the pulmonary vessel. I hope that I have covered all, if not most of the, most, if not all of the questions that come in the pathology small group lab exam. And I hope that your performance will be as you have shown in the past, that your performance is excellent. I am proud of all of you for that. And I hope that you will maintain it. So I wish you the best in your coming.
Thank you, Dr.
Thank you.